Hey everybody, so we're back here. We have a new patient today with us for StemWave treatment. We're going to be looking at his left knee. He's coming today telling me that he's got the swollen... Hey, why don't you interrupt the video? Why don't you interrupt the video? Why don't you interrupt the video?
Because I haven't seen him.
Get a blooper reel. Look at that.
Yeah.
Your brother said I won't have time to adjust you today, so I just want to say
That's fine. I'll be back.
I screwed up. I'm sorry.
You're good.
Okay.
That's good. We're going to keep that. I'll put that front page. That's going to be like thumbnail. Okay, so we have a left knee pain. How long ago did this start?
Probably about a month.
A month ago. So he noticed kind of like a golf-sized ball protruding out of the back of his left knee. So typically when you hear that, you think automatically of a Baker's cyst. And that could be what's going on. Sometimes that's a cause of arthritis, or if there's been previous damage to the area, that could be a cause of it as well. He has a history of exercising in the weight room. He's a basketball player, and you damaged your knee, you said years ago. Was it in high school?
Probably about 10 years ago.
Okay, 10 years ago, and was it playing basketball that you did that? Okay.
Yeah.
So I think it's important that we take x-rays of his knees today to get a clear understanding of how the joint line looks, to see if there's any calcium in there. That could be, you know, signs of arthritis, any bone spurring as well. Hold still. Here's the one in question. Great looking joint space. We look at the edges of the bone, the cortical margins, looks excellent. There's no jagged edges, there's no spurring, no free-floating calcium densities. Okay, so on the left knee, a medial wedge tells us it's a femur issue. And this is, because this is wider here, right, this femur is rotated externally. The good news is there's no signs of arthritis from the x-ray. That's really good. So first and foremost, here's our applicator head. Inside this applicator head is a special spark plug that they've developed that's sitting in a solution of salt water. It's going to continuously spark electricity, salt water. They don't like each other, so that's what's creating our plasma bubble, a small explosion inside that applicator head. And the shockwave that it generates is then submitted into your body through this little membrane here. I have control over how many shocks you get per second, and then here's our energy level. You could think of it kind of like depth penetration. It's a lot different if I need to get into an elbow versus a knee, a shoulder, low back. So shockwave therapy has been around since 1999. It was like born out of lithotripsy, which is what they used to use to pulverize kidney stones. And then they kind of noticed it was having some kind of regenerative effects. So over a past couple decades, they've developed it. StemWave is a company out of Boston. The golden ticket to all of this is this, this receptor in our cells called TLR3. Certain cells, when they're hit with a shock wave, they're kind of thinking that they're being damaged, and they do this thing called expression, and they express this receptor called TLR3. I tell patients to think of it like a flagpole. They kind of like stick it out through the cell membrane. Other cells in the area will see that this is happening, and it triggers this whole cascade of events to occur. The first thing is shutting off voltage-gated sodium channels, which is our body's way of signaling pain up to our brain. If we could shut that off, we can help patients with pain relief. The second thing that happens is it kind of turns on one of our white blood cells. They're known as macrophages. Their only job is kind of go around, they see debris, and they see inflammation, and they kind of just eat it up. The third thing that happens is recruitment of our body's stem cells. They'll kind of be rushed to the area, in this case your knee. Stem cells sit in our bone marrow, our fat tissue, they're in our bloodstream. This will kind of trigger your body to not only have stem cells multiply, but have them kind of flood the area of the knee. Last step that happens is a process called angiogenesis. It's a fancy word for new blood vessel creation. If we're going to have stem cells come in and start identifying damaged tissue and replacing damaged tissue with new healthy tissue, we need to keep it healthy, and the only way to do that is with a new blood supply. Now, their research shows that that process takes a minimum of 4 to 6 weeks to occur, so we don't offer any treatment plans that's any less than that. So we're going to be doing 800 shocks. You'll get 2 every second. I'm going to start the energy a little bit lower, and normal will kind of gradually go up, okay? So again, right now I'm just going over certain landmarks in the knee that I'm familiar with, that I know I want to be on. And of course, because he came in today with a Baker's cyst, what we think is a Baker's cyst, it's not a confirmed diagnosis. He would need an MRI for that. I'm going to make sure I'm over the posterior knee as well. He's mentioned that while he's working, going up and down ladders, he works on roofs, he's experiencing instability in the knee. It's been very sore, so we want to make sure we kind of just support the entire joint itself.
That area right there that you were just at?
Right here?
Yeah.
So this is more quad tendon. So here we have the VMO, the vastus medialis obliquus, that kind of comes in, one of our quad muscles, to then form into quadriceps tendon. It stretches over the kneecap and then forms the patellar ligament right down here. This is a very common area for patients to be sensitive. Are you filming here or are we filming there? We have both.
Look at that, dual camera.
Multi-cam show. Nice. I like that. So now I'll kind of shoot into the center of the knee. How's it feel here?
That's good.
That's okay?
Yeah. It feels, I'd say, the same as that insertion point we were just at.
Okay.
Like it's more sensitive, but not painful or anything.
Yeah, good. And again, I'm going to make my way to the posterior knee to make sure we hit this cyst and this posterior capsule.
I'd say the same, yeah, the same as that
feels
first
a little
tendon.
sensitive.
Yeah.
So this area is called the pes anserine. One of our hamstring muscles attaches in here, as well as some adductor muscles, our sartorius and gracilis. For those anatomy nerds out there. Now, has this calmed down a little bit?
Yeah, it actually has.
Yeah, but this is a long process. It's a compounding treatment, so the more sessions we do, the better the results. Just because we're gonna run out of the 800 shocks today, that doesn't mean his body just stops this healing process. This is a continuous process that's gonna be ongoing over the coming weeks while we continue to do these treatments on this knee. We're all done for today.
It's easy.
Till next time. Yeah, it is
Look at
easy.
that.
Very straightforward.
So that lack of sensitivity from the start to the end is actually...
Yeah, that's like like our nerve cells that like these gateways. It's like they open up and they rush sodium in, but it's like, and when that happens, it kind of excites our nerve cells, and that's what's signaling our brain. And sometimes those gates can stay open when there's too much pain, too much strain, or damage to a muscle. It's like people end up getting chronic pain like that.
Yeah.
So this kind of helps close that pathway.
That's amazing.
Yeah, it's pretty remarkable.